To everyone, I'm Leticia, as Dr. Fraga said. I will present a case that was in our service a few days ago, and here we go. We don't have any interest conflicts, and let's start it. In the trauma notice was around 10 to noon. And there was a female around 27 years old, and about the scene, they say to us she was a victim of motorcycle crash against a light pole, and she was wearing a helmet, and there was at that time no history of velocity or laterality. And then the pre-hospitaler team passed the case with crash accident, with abdominal and fascial trauma, and with abdominal tenderness, and they just did some crystalloid. And about the ATLS at the scene, they could control the oral bleeding. She was breathing spontaneously. Saturation was good. Respiration rate was also all right. But she had abdominal diffuse pain with blood pressure around 90s, and the heart frequency was 125, and she was a little bit confused, and in the extremities, nothing just too relevant at the beginning. So they did the cervical spinal restriction and put some oxygen in a catheter. They cut venous access with the crystalloids and spinal board, control of hypothermic prevention, and they transferred to a trauma center here in Unica. Here at our ER, we started attending her around a noon and a half, and the airway maintenance was with cervical collar. She was communicative, conscious. She presents some dental injuries, but controlled bleeding. Within B, we see some symmetrical chest expansion with normal vesicular breath sounding. Saturation was 100%, and we put a mask reservoir device with 10 liters a minute, and she was fine at that moment on B. And C, her heart frequency was 120, blood pressure was dropping, so she was 8450. Skin perfusion was good, but she had this diffuse abdominal pain with bundle tenderness, with no evidence of pelvic fracture or major bleeding or some other significant symptoms or signs in her abdomen. And within D, she was with a Glasgow scale of 14 because of some, she was a little bit confused. But pupilla was isophotoreagent. She had retrograde amnesia, and in E, we had just some superficial bones on left side of her body, just superficial, and we did E-FAST. In the E-FAST, we see, you could see free liquid in the spleen and hepatorenal, and there was some fluid there. She was here.
So just to remember, was a young female motorcycle crash. The velocity is about 70 kilometers per hour, and she arrived 30 minutes after the event. She was a little hypotensive at the scene, and when she arrived after 1 liter of crystalloid, she maintained with hypotension. So the discussion, the fast was positive during the admission at the emergency department. So I think you can open for discussion at this time if this patient needs to go to the OR or if she can go to image, to go to CT. So Gary, please moderate the discussion about this.
Yes, sir. Let's start in Portland with Dr. Kasim. Your comments, please.
Well, Dr. Fraga has given us a better picture of what the case is all about. And I just like to correct one thing. You cannot determine pelvic fracture from the clinical examination. So, you know, you can't say the patient did not know evidence of pelvic fracture. That you need to get an X-ray to determine that.
No signs of pelvic fracture. The pelvic examination was normal.
Right.
Was normal.
Well, even then, you can't quite rule out if there was any injury to the pelvic bones or not at this moment. So she's hypotensive, and you've given a liter of fluid, and she is still hypotensive and tachycardic, and she's got abdominal tenderness, and you do a thorough examination to make sure she does not have any obvious limb injuries, such as lower extremity injuries, because if you have lower extremity injury or rib fractures or fractures in the upper extremity, all these areas you could lose blood, and that will add to her hypotension along with whatever is happening in the abdomen. So you did a fast examination, and she is positive for hepatorenal fluid collection. And I don't know whether you saw anything on the right side. I would suspect there might be some fluid there as well, but I didn't get to see it on the sonography at this moment. So following the ATLS guideline and guidelines from the East, a patient who is hypotensive and not maintaining blood pressure and tachycardia with abdominal tenderness and fluid in the area, by and large, should go to the operating room rather than CT scanner, because a patient like this, if you put her in the CT scanner, there is a good chance that she might crash. And also, the other point would be, should you be giving this the patient any more fluid? The answer is no. If she does need volume, you should deploy blood transfusion or plasma, most likely blood, you know, even if it is uncross-matched type-specific blood in a situation like this. But she's a female, that you have to be a little cautious about that as well. So I think my gut feeling tells me that this is going to be a patient who is going to have some type of a solid organ injury, most likely the spleen. And the question is, should you take this patient to the operating room, or should you start thinking about non-operative treatment by giving a fluid, in other words, blood? I am old-fashioned, and I can give you my age, and I think I would sleep better if I take the patient to the operating room to get the problem solved. Thank you.
Thank you, Dr. Kasim. Let's go to Norfolk, Dr. Grigsby.
Yeah, so I make sure I have good access on the patient. Throw in a cord if we have that available. Yeah, the plan is to go to the operating room and not to waste time in the scanner. We have whole blood readily available. Not an unlimited supply, but we would have it ready in the trauma bay and would start with that. And for this patient, if tachycardic and hypotensive, and sorry, my pager's going off.
Thank you very much, sir. Dr. Rodriguez, your comments, please.
Yes, thank you very much. This patient, repeat what everybody said, hypotensive, tachycardic, you know, and unresponsive to at least 1 liter of fluid, and complaining severe abdominal pain, seems more moderate pain, abdominal pain. I don't think anybody in the world would criticize that you take this patient to the operating room. That's the rule. Unless this patient will be positive fast, but normotensive. That the next step will be CAT scan in that case. But in this case, I would, even I'm used to have a CAT scan 2 meters away from me, which case we transfer, not the patient, we transfer the whole team to the CAT scan, even though I will go for the OR. And more likely as this is solid viscous injury. However, I worry about this severe abdominal pain. There's one thing give you severe abdominal pain. Normally, nothing in the beginning and then severe abdominal pain is small bowel injuries. Okay, so he could have, in addition to solid viscous injuries, could have a small bowel injury.
Thank you, Dr. Rodriguez. Baghdad, Dr. Untract, your comments, sir.
Yes. Okay. Well, I think Dr. Gonçalves laid out all the elements of the history and physical exam very nicely, very clear, very easy to follow. And this is a very classical case where really the only appropriate course, given the facts as stated and the evidence, is to go straight to the operating room. I wouldn't spend time to x-ray the pelvis. I think there are no hard signs of a pelvic fracture. There's no bruising, no lacerations in the area of the pelvis. And so this very concerning in a young patient to be not just tachycardic, but also hypotensive. So I agree with everyone else, go straight to the operating room.
Thank you, Dr. Untract. Let's go to Philadelphia. Dr. Alex, your comments, please.
Hello, everyone. Can you hear me?
Yes, sir. Loud and clear.
So I agree with all the comments. Definitely access, definitely MTP. In terms of imaging, this is not the right patient to go to the scanner with. You know, mass transfusion protocol and proceed to the operating room. I do think there's still a few seconds to shoot a pelvic X-ray, and if there is any fracture, I would put the binder. And that's all I have in terms of comments for now. Thank you.
Thank you very much, Dr. Alex. Dr. Fraga, just in case you wanted to take a look, there are some comments over in the chat. If there's anything you ever want to comment on or a question over in the chat that you want to answer, you can take a look at that. And with that, if there are no other comments, we'll return back to Campinas.
So this is a difficult situation when you have a patient was unstable and we start the resuscitation with crystalloid. So you activate the massive transfusion protocol and wait to give 2 units of blood to take the decision to go to the OR or to go to CAT scan. So Dr. Leticia, what we did?
So next, after the EFAST, and here, we started with monitoring, get some laboratory evaluation, especially with gasometry, gas analysis, and we put a next exit with morphine. She was a little bit in pain, and we did the massive transfusion protocol. Here we did 2 RBC and 4 FFP with image testing. The time you all can see, we could bring her actually really fast to the CT, and after the second liter of crystalloid, she was a little bit more stable, so we could do a CT. And just before the CT, actually, here is the first laboratory analysis, and she was not accident alteration, but her excess basis was less
minus
minus 82, and lactato was
8.2.
4.1, and her blood counting was not that bad. It was 9.6, and here.
lactate 4.
Yeah, 5.1, like that. And hemoglobin 96, and that's it for the beginning. And then we bring her to, as I said, some more, what, here.
So after 2 units of blood, the blood pressure was 100 plus 60. The patient looks better, and the decision of the surgeon who was on call was take the patient to CT, because the idea is identify the injuries and possibility of non-operative treatment. The patient recovered well after 2 units of blood.
Well, when we see that the blood pressure was not dropping anymore, we bring her to a CT that you all can see there, I guess. Here is without contrast. Here there was some fluid, as we saw in the EFAST. Here, after with arterial phase, there was the evidences here were the main ones were the liver, the spleen, and renal.
So there was a grade 4 liver injury without blush. There was a grade 5 splenic injury without blood. And there was a renal artery, maybe Intl laceration, because no perfusion on the left kidney, and there was no blush around the kidney.
The discussion with the radiology team, they explained to us, and we could see an extensive laceration of the liver, since from diaphragmatic domus unto the hepatic hilum and near to the vascular structures. In the spleen, it was similar with high-grade traumatic lesion, hypoperfusion, no contrastation of the parenchyma, and deep lacerations through the hilum, and also nearby vascular structure. And about the so about the renal lesion, there was an abrupt arterial occlusion of the left renal artery, almost total hypocontrastation of renal parenchyma persistently until lately phase of the study, suggestive of ischemia, accentuated hypoflow. And also in the adrenal gland, left one, there was an heterogeneous and diffuse thickened parenchyma, unlimited superficie, suggestive of also contusion. So there was like 3 special and aggressive injuries.
So after CT, the patient was tachycardic, but the blood pressure was around 100. The patient was better, and you observed 3 complex injuries: liver, spleen, and kidney, with a grade 5 kidney injury. With you can see the renal artery on the left, but no perfusion on the kidney. So our team have a WhatsApp group with our attendees, and we started the discussion. Let's operate these patients or try the non-operative treatments. So I want to listen the different opinions. The patient had criteria about the stability for non-operative treatment, but the injuries were very complex. So let's start. There's another image? No. No. So this one. Gary, please.
Yes, sir. Baghdad, Dr. Untract, your comments, please.
Yes, I just want to make sure I heard correctly. The spleen had a high grade laceration. In other words, avulsion of the spleen. Is that correct?
Yes, we consider the
okay. Okay. All right. Yes. Okay. Well, that's actually that's not something for non-operative management. That's avulsion of the spleen. However, you're raising the question, and if you have especially if you have a hybrid room or your interventionalists are very good, I think it's reasonable to salvage the kidney. I mean, it's a young woman, blood pressure of 100 with tachycardia. I wouldn't be comfortable with that, but you're there with the patient, you're seeing her condition. If she's awake and feels comfortable, the blood pressure is okay, then I think that might be an option, but it's aggressive. I think it's somewhat off the mainstream, but especially if it works, if you have good interventionalists, salvage the kidney, and at the same time, I think put a coil in the splenic artery to prevent bleeding, and then you're likely going to have to go back later and remove the spleen, but you can do that, morcellate it in a bag laparoscopically once she recovers. I think that might be an option, and that's more of a novelty. And I think any instability along the way, as you'd have to abandon and do a laparotomy, get control of the bleeding. And then if you haven't put the stent in the renal artery at that point, you'd have to decide whether to go ahead with a revascularization in the operating room. If the splenic artery is patent and you're doing a splenectomy, you can on the left side do a splenorenal shunt distal to the obstruction. That would work. It's not that difficult. Or you can take a chance then and not revascularize in the operating room, then go back to angiography. But again, that poses the risk of not being successful and having to make a second trip to the operating room. So it's really, I think it's more of an aggressive cutting edge approach. But if you have the team to do it, I suppose that's might be what you did in this case.
Thank you, Dr.
Just to remember, the time between the trauma and the CT was about 90 minutes. So you did the diagnose in a good time to try to save the left kidney.
You say 9 minutes or 90 minutes?
90. 90.
Okay, so an hour and a half.
An hour and a half. Perfect. Thank you.
All right, Dr. Rodriguez, go ahead and continue, please.
Okay. Trauma is very simple. We make it difficult, Okay. In this case, if you ask 90% of trauma surgeons in the United States, I think with the patient hypotensive, tachycardic, base deficit of 8 is in shock. More important than all the blood work you did, base deficit of 8.6, no 82, 8.6, okay? This patient have to go to the OR. And I think very few people will take this patient hypotensive, and the situation he is, to the CAT scan. Even I work in the Intergalactic Shock Trauma Center, the Universe Shock Trauma. We have the CAT scan next. Even there, well, I don't think I would take it there. Now, we went through the other route, and that was good. It was good because we found stuff that probably you're going to suffer in the OR, probably there. You find those things. Yeah, the question I ask is, what do we do if I open the belly? What at that time? What would be my? You have a liver injury that hopefully will stop with something or pocket. Okay, the spleen can be taken out within 15 minutes. That will be no problem. I wouldn't try to mess around with the spleen. The spleen is out. If it's like you describing in type 5, it doesn't going out. Now the kidney injury, that's another story, you know. You open Girotta fascia, the kidney is out. You don't recommend open Girotta fascia. First, you have to be sure it's kidney on the other side before you do all that, okay? So I think the situation is different. If you go into the belly, I would like to hear what the guys will say, will do. If you do this approach that is, at the end, probably is going to be good, you know, but actually it would help because as you see, coil in the spleen you want, patient is a stable, quote unquote, stable. I don't think it was stable. He was in shock. Base deficit was minus 8.2. Okay, that's my opinion.
Thank you very much, sir. Let's go to Dr. Alex, Philadelphia.
Interesting findings, definitely a challenging situation here. So to respond to this, so basically from the ischemia, warm ischemia standpoint, I think I agree with Dr. Untrak and ask interventional, radiology, cardiology, or vascular if they can salvage the kidney. But we need to balance the amount of work that needs to be put into that because you're going to give a lot of contrast and you're going to have only one kidney left. And you have to keep in mind that after you do a procedure like that, you're going to have to anticoagulate. So you cannot just leave an evolved spleen without an intervention, which should be probably done at the same time, as Dr. Untrak said, with coil embolization of the splenic artery. And then kind of watch and see what happens with the liver. My initial comment was to go to the operating room. So in the operating room, I would have removed the spleen, put it in the bucket, pack the liver, and then go to the CT scanner with IV contrast. And then I would have seen the kidney, would have still been in the warm ischemia time. And I would have asked at that time, vascular, if anything can be done interventionally for the kidney. These are my comments. Thank you.
Thank you, sir. Portland, Dr. Kasim, your comments, please.
I like Dr. Rodriguez's idea. Why are we making this case difficult? For centuries, we've been doing this type of case and patients have done very well. The dictum in surgery is stop the bleed first. That should be our goal in surgery. If the patient is bleeding, demonstrated by hypotension and tachycardia, stop the bleed. The patient has a severe splenic injury, and I think anybody who wants to do non-operative treatment either is very brave or Dr. Trunke will call it stupid. That's what he would call it when he was alive, anyhow. So what I would do in a case like this, I would not have too much discussion. I would tell my residents and myself, my other staff, if I'm there as a consulting physician, that we are going to go to the operating room and act like surgeons. And in the operating room, it'll take me 5 minutes to remove the spleen and 10 or 15 minutes to pack the liver. And then I would take 2 minutes to contemplate what my next move is going to be. I've already done a splenectomy, so the splenorenal ligament is all torn apart and is gone. And I could do a left mattocks. And then I can look at the left kidney, look at the left renal artery, and I'm a vascular surgeon. I know how to deal with this, and I'll go ahead and deal what I want to do with the left renal artery and get a picture if I want, or explore it, or repair it, and get it perfused as quickly as possible, because I still have plenty of time available for the ischemic injury to the left kidney. And that's what I would do. And if I want, I could leave the abdomen open and go back and remove the packs from the liver the next day, or contemplate doing something like that in 48 hours, or close it if I wanted to as well, if the bleeding is stopped in the liver. That's what I would do. Thank you.
Thank you, Dr. Kasim. Dr. Grigsby, Norfolk, your comments, sir.
Yeah, and I'm kind of agreeing with the same. You got a guy with a base deficit of 8.2. There's not really a role for non-operative management here. I think we're already way behind. So take them to the operating room, pack the liver, take out the spleen. You know, one thing that I haven't heard a lot, you know, there's a big retroperitoneal hematoma over in zone 2 on the left. So it's going to be not just even the ligament on that side, but we're going to take down the whole white line of Tolt and look at that retroperitoneum there. So we're going to see all that injury to all that, get out all that blood, see the injury to the kidney. I don't know exactly how if I would have the expertise to repair it or not, but you know, we need to make a decision about that and then keep the liver packed. Probably come back in a day for those packs, but you know, this is definitely a tough case, and this is also one that, you know, come in hypotensive without the scan or even with the scan, like this, someone in the OR that you got to think about getting supraceliac control first, or you have to get a Reboa. Probably in my hands here, it'd be supraceliac control.
Thank you, Dr. Grigsby. Dr. Calais. Okay, you're.
No, I'm sorry, I'm late. I was operating here in São Paulo,
Yes, sir.
and I don't know what will happen. I think the patients have a blood trauma. I don't know, but I think they have a liver injury with extravasation, with blood extravasation or contrast extravasation of the liver, and I see exclusion of the kidney. Kidney may be excluded, the left kidney. And hematoma peri-renal. That's the patient is stable or not stable? I believe these patients are unstable. So in this moment, if I have to say, they put these patients in the OR, they make a demo control surgery. I agree with Dr. Cassin that take off the spleen and tamponate the liver. I think it's very important in this moment for the patient. Very difficult to force. I believe that this is the reason that I can see. Okay.
All right. Thank you, Dr. Calais, for your comment. Go ahead. Okay.
Any other was a grade 4 liver injury without blush on the liver. Grade 5 splenic injury without blush, and a grade 5 kidney injury, renal arterial injury with the intimal laceration, no perfusion on the left kidney.
Hey, Gustavo, how much blood you found in the belly when you opened? How much was a lot and a little bit?
You tell later. We will tell later. At this point, the patient received. I think the critical point for discussion is about when the patients arrive at the emergency department. The patient has a blunt trauma. She had abdominal pain, and she was hypotensive and tachycardic. After give blood, the patient recovered. I don't know if you have the arterial gas, but the patient was better, and this was why you sent the patient to CAT scan. After CAT scan, the patient was better. The patient was better. So in the past, I think there was no discussion about the treatment of this patient. I think everybody should take this patient to the OR. But nowadays, with interventional radiologists, non-operative treatment, some case you can try to treat non-operative. I think this is the more difficult discussion, because as I understood, about 50% go direct to the OR, and I think there are 2 or 3 hospitals who suggest try interventional radiology. So I want to ask, because there are some papers, when you have a complex injury, the liver, on the spleen, to have a angiography of the the kidney, the spleen or the liver. It's not routinely in your service, but you try to discuss with the vascular team who perform the arteriography in your hospital. So you call the vascular team to ask for arteriography to try to save the left kidney. Because, you know, if you go to the OR, you remove the spleen, splenectomy, maybe nephrectomy on the left, but it's a young male, female, only 27 years old. So we are trying to save the left kidney. So Leticia will tell the history of the patients.
So after the CT scan, sorry.
Okay.
Gustavo, may I ask a question?
Yeah, sure.
You have a problem. You have small injury of the kidney.
We cannot hear you, doctor.
We cannot hear, Cole. We cannot hear.
Yes, let me see. Let me see. Okay, you can hear better.
Okay, very good. Go
Okay,
ahead.
okay. You have a problem here. You have an injury of the artery, renal arterial, left renal arterial. How much time the patient stay with ischemia? How the trauma and the patient is in the OR or in the emergency room? Because it is a hot ischemia of the kidney. Sometimes, if you try to revascularization, it's not very good in this situation. Sometimes you can't put this patient in the OR. You take the spleen. You never see the kidney, and although if the patients have injuries that can blending for the kidney, you cannot open the fascia of the kidney in this moment during the surgery. You can remove the spleen and don't explore the kidney. The ischemic injuries of the renal artery of the kidney usually be a finding in some can see on the CT scan when we make in a trauma. Sometimes I see some people trying in our hospital to revascularization this artery, try to put a transplantation of this kidney to the other place. And usually the problem that they never recover the kidney and maybe aggravate the patient. So in my opinion, when you have injury of the one artery of the kidney, which is ischemia artery of the kidney must take in place and wait. Can sometimes they recover maybe later, or this kidney may be atrophied and problem later. Sometimes you can make a nephrectomy. At this moment, it's not important. This type of the injury of the kidney. I said with the very big hematoma because of the spleen and the laceration of the liver. So if the patient can be stable, you can go to angiography and try to embolization. Sometimes the spleen artery, but I don't. Sometimes it's very difficult to salvage this kidney. So it may be problem with the patient. So may be careful when you see these injuries in the CT. Sometimes I saw here in São Paulo these injuries, and some people try to fix these injuries, and it's not very good results.
Can I say something succinctly? Okay.
Sir, please.
Succinctly, okay. If the situation is different scenario, if you do what 80–90% of people we do in the United States, okay, despite they have the technology that is more common in Brazil, seems to be, we just did the DQT in Spain, and we were criticized because we talk about angiography embolization, and that's Europe, okay? All right, but I am sure in the rest of Latin America, in Peru, to get an angiogram embolization, you have to go to a private clinic, okay? Because you don't have that in the regular hospitals available. Okay, this is the question, okay? Dr. Colette, I think he's having a heart attack there. No, are you okay, Dr. Colette? Okay.
He's talking to his people.
Okay. You know, most of the people, those two scenarios. One, you enter the belly, like most people will do. Okay, we already repeated. We take the spleen out, 5–10 minutes. We pack the liver, pack. The kidneys, I don't know the description Gustavo was. It was a grade 3, 4, 5. Was sanguinated the kidney, yes or no? Oh, okay. Now you are talking on basis of the CAT scan that doesn't show perfusion there. But you open the belly, you didn't know that. All you know is the kidney is bleeding. So there's two options. Either you open your rotafascia, which is bad because once you open your rotafascia, it's 90% chance that you end up taking the kidney, even if it doesn't need to be taking the kidney. But if you do what you always do, the proximal control the hilum and then open your rotafascia, then you can see what's going on. But I doubt it at that moment, you're going to say 100%, oh, there is a renal artery injury here. That's the scenario, okay? That's one scenario. And the other scenario is the one you're discussing, Gustavo, which you went to CAT scan, you find all this, and then you have to make decisions. Doctor from Philadelphia is concerned about the ischemia of the kidney. Fine, I think that's a fair point. That was not succinct, but I wanted to say two different scenarios. Open the belly or doing what Dr. Gustavo did, which is nothing wrong, guys.
Thank you very much, sir. Go ahead, please.
Okay, Dr. Aurelio, I agree. But now I think you have another problem because you have the CT. If you go to the OR, when you have only a grade 4 hepatic injury, the morbidity is very, very high, the morbidity. I know you need to do a surgical treatment in case like this one, probably. But the kidney was probably intimal laceration of the artery, and you can see without the contrast that the left kidney, maybe the aspect is not so bad because you have a hematoma, because of the spleen, there's a small perfusion on maybe there's a polar artery. If you go to the OR with the patients, probably nephrectomy will be necessary with splenectomy, probably. If you go to the OR because you have a large hematoma, a lot of blood on the belly. So this was the discussion. And we had time to discuss in our group. We had a group by WhatsApp to go to the OR or try to do a non-operative treatment. And the patient, after 2 units of blood, was better. Was only with tachycardia. So the decision of the group was send the patient to the ICU and try a non-operative treatment. This was the decision in our group. We discussed with the vascular team to try arteriography, but go ahead, Leticia. They told that probably was very difficult to treat by endovascular because they need to have a catheter for the renal artery, and you ask them to discuss with the vascular attendings to try to save the left kidney. The urology, they suggest you non-operative treatment and try to save the kidney, because if they go to surgical treatment, it's very difficult to save a kidney like in this situation. So it was a long discussion. The option was non-operative treatment for the patient, and the patient was sent to ICU. More discussion, so you show later what was the result. Cole, do you want to talk, Cole?
Gustavo, I agree with the comments. I believe that the patients, the kidney cannot not have you don't need to fix any problem in the kidney. You can wait. The great problem is the injuries of the spleen and the liver. If the patient is still stable, you can try to make a conservative management and then wait. If the patients go decrease these parameters, you can go to the operating room. So, but I think during the surgery, in this situation, if I go to the surgery, I tried not to open the left kidney. I take the kidney in place, not try to exploration the kidney at this moment with this image of the tomography. But with the spleen, I believe if I go to the operation, the spleen, I go to splenectomy and tamponate the liver. But I agree with your comments that the patients, when to try to make adhesion control in these situations, maybe sometimes if the patient is stable, you can aggravate the patient. So the patient is stable, can wait. But if the patient cannot be stable, you can go to the surgery.
Well, that's
the way that, yes.
A philosophical question, doctor. What is a stable patient means for you?
I agree with your comments.
Just a minute. I was giving a lecture in the Metriades place, okay, whatever it's called, Southern California. And he asked the same question to the audience. We're 300 people there. There were 300 opinions. What is hemodynamic stable? Now I know there is a definition, the 3 or 4 things need to be. But this patient, all what I want to say is that I think Gustavo was right. He took an approach and he followed to the end, and probably patient is going to do well. But you cannot say that because you give to 1 unit of blood or 2 units of blood and the patient became quote unquote stable, that means that the patient is okay. Because unfortunately, Gustavo, we don't have another blood gases to this demonstrated that the base deficit is better. Because that's 8.2 definitely bother me, you know, that means for us, that patient is in shock. Now, it seems like we give a lot of importance discussion in this case to the kidney. It's important, but I think I agree with Dr. Colette. We should see the whole global thing, you know. There was a major liver injury, it was a major, well, spleen is out, and there was probably other things that haven't told yet. So I think, I don't know, I think, Gustavo, you're trying to say there was a consensus, right? A consensus group that say that probably they agree that the non-operative management was okay. That's what you said, right? Okay. We have a lot, by the way, for the people who is no Brazilians. I am from Peru. I train in the United States, but I live all my life in Peru. We have a tremendous respect for Brazilian surgeons. We thought that that's the best technical surgeons of all Latin America. And I don't have any question that consensus group that you have was people who understand very well all these areas. But again, I repeat it, most of the people in the United States in these circumstances, I think they will go to the OR and get in all these problems that we talk about. But always going to be people who is a little bit more, have more guts like you did and took it, provided, I'm sure you were there, Gustavo, somebody senior was there. That's important because you cannot handle the resident, this patient like this, has to be an attending there present with all this. I'm sure you did.
And the problem is the North Americans, they teach us how to do non-operative treatments because it's very difficult to have the decision in this case. Because you talk about the stable, I think is the most difficult situation on trauma is definition about who patient is stable. Because you have the vital signs, you have the arterial gas, so many information. And during a Congress, I don't remember who answered it. You start to learn who is stable when you have a lot of white hair. So you have a large experience.
I tell you,
the patient, you say, this is stable, this is not stable.
I tell you who answered. The person who answers is probably somebody who never takes calls or doesn't do trauma. Unfortunately, that will happen in the United States. Sometimes the people who answer those questions, those esoteric questions, are people who say, oh, this is for professional, but they never have been taking calls on trauma. That you are in the spot, you know how to do trauma. So,
okay, so let's if you, the surgeon who suggests have the arteriography, what they suggest to do if you observe intimal laceration on the renal artery, it's possible to put a stent. You have experience because it was only 90 minutes, 1 hour and a half after the trauma. Most of these patients in your hospital, when they arrived after a blunt trauma, usually they are stable because they have the CT in other hospital. It came to our hospital to treat, to have a angiogram. Usually they arrive with 4, 5, 6 hours. This patient can direct from the scene to the hospital. Dr. Alex, Dr. Grigsby.
I'm sorry, Dr. Fraga. Okay, go ahead. Yes, go ahead.
So, as I said, you know, in the operating room, I would have taken the spleen out, packed the liver, and then get the scans. Okay, that would have still been, let's say, maybe, you know, the warm ischemia time would be, I think it's up to 4 hours. So I would have had the scan. At that point, I would have reached out to vascular and kind of go from there in terms of, you know, and, you know, we also even have like transplant surgeons around available. Is it worth pursuing this endovascularly or not? I don't have that much experience with this kind of cases, but anecdotally, everything that I heard in terms of, you know, opening the renal artery and taking the clot out and close, that results in taking the kidney out. Transplantation of the kidney for a situation like this adds more injury to the patient and the outcomes are not good. So probably this kidney would have been, you know, alone, left alone. In the situation of really non-operative and as this case progressed and get the CT scan and with these findings, now this patient blood pressure is better, got some blood, it's worth, you know, repeating all the labs and see, is he correcting the lactic acid and is he heading the right direction? That's one thing. The other question, you know, the next thing would, you know, would be, if I were to encounter this, again, reach out to vascular and angio. Is it worth going? Now it's like an hour and a half and I got the scan. Is it worth I would embolize the spleen. So, because now you have three things that can, you know, create complications in the unit. He may drop the hemoglobin or the blood pressure. Where is he bleeding from? At least the embolize the SMA, and that should be off the table. And then you have to worry about the, you know, the liver and the kidney. So in the sense of embolizing the spleen and see if anything can be done endovascularly for the kidney artery, again, that would be a question for, you know, for vascular, if it's kind of worth pursuing without, and that would now be like, okay, this patient goes and sits in the IR suite and the trauma team is not there. Like we go there, we stay, one try or whatever, and that's it. Stop. We're not going to let them go in the land of isolated organ treatment because this is a sick patient. So these are the comments I have.
Thank you, Dr. Alex.
We would
Dr.
have-
Bravo
we would
has
have-
Dr. Bravo has had his hand up for quite a while. Would you like to go ahead, Dr. Bravo?
Hi.
Hi.
I'd like to make a salute to everyone.
Hello,
Sorry to interrupt because according to the AAST, this is a lesion grade 5. It means that it's a vascular injury. It's described optional treatments to the take some stitches to the artery if it's not a complete lesion, and when it's a complete lesion, you can make an anastomosis or venous purge, something like that. But when you are trying to make an alternative treatment, in this case, instead of nephrectomy, it's described you can call to vasculars and they will try and they will try this alternative treatment. But in the AAST, in lesion grade 5, it's described that when you make this kind of treatment of endovascular, that it have as a success of just 52%. It means that the measure of probability of angioembolization, it may not resolve. So you're seeing it's like drop a coin and have a 50% probability that it won't work. So if it's in this context, it's a patient hemodynamically unstable. So I think that maybe endovascular angioembolization is not the right choice right now. So that's my humble intervention. Thank you very much.
Thank you, Dr. Bravo. Let me go ahead, please.
Yeah, I think we're losing here something. Okay, I think the main theme here for me, everybody's concentrated on the kidney, the damn kidney, but patient has a major liver injury and the spleen who was embolized, you know, and has suffered other injuries we don't know yet. You know, I think that's more concern. And the discussion of Dr. Gustavo was to operative management, non-operative management. Now we're going to the kidney. We want to save the kidney. You know, it's okay. I know Alex is, Dr. Alex is concerned about the ischemia of the kidney. But remember, you know, in the old days, we didn't even have CAT scan available. The patient start developing symptoms. This because this conference, I guess, is not for 4 of us. It's for 20 people who's listening, probably residents who need to learn that when you didn't have the way manifestation, clinical manifestation of that kidney are back pain, when you don't know why your patient is having so much bad pain, you know, that's in hypertension with no explanation. That's clinical diagnosis of dead kidney when you don't have a CAT scan, okay? So it doesn't, okay. Now the question here, my first point was the discussion should be centered with global discussion, not concentrated just in the kidney, okay? Now, if you enter, I keep repeating, if you enter in the OR and your kidney is bleeding, either you open your autophagia and more likely you put your hand on the other side, be sure it's a kidney on the side, and you take a kidney out. Sorry, it's 27, but you take kidney out. Or yeah, I'm at 3 o'clock in the morning, I'm going to be thinking about the classification of the AAST that you love so much. AAST is the classification, you know, which I never learned because at 3 o'clock in the morning, I don't know the difference between 3 and 4 and 2. I know it's a bad kidney or it's something I can save it. I'm sorry, Dr. Bravo. You know, I know you love the classifications, but at 3 o'clock in the morning, it's very difficult to think. This is a major laceration. I see this is going out, or this is something I can do a polectomy, a partial. It's very simple. Anyway, this is a different situation. And then we're talking about endovascularly, call the vascular surgeon. All that stuff is possible to be done. But remember, this is a sick patient, honest to God. He has major injuries. The kidney is something we have to think very seriously, but it's not the main issue in this discussion. I hope not. I think Gustavo didn't intend that this was going to be discussion about saving the kidney. It was going to be non-operative manager versus operative manager. That was the discussion, I think.
Okay, sir. Let me direct this back to Dr. Fraga to see if he wants to continue for comments or if he needs to continue. Do you need to continue, or would you like comments from the crew? We haven't had any from the whole group. Dr. Kasim has his hand up. Let's go to Dr. Kasim, please.
I think we are making this case very difficult. I don't know why. You know, a patient has trauma and he's bleeding from the liver, he's bleeding from the spleen. And grade 5 splenic injury, there is no room for a conservative treatment. You know, I think that is a dictum in surgery. So once you have that kind of magnitude of injury to the spleen, the spleen belongs in the bucket. So once you have dealt with the spleen, it's going to take you a little time to fix the bleeding in the liver, unless you're going to remove the liver, which is not feasible. So packing the liver is going to take time. To stop the bleeding is going to take a little time. And then by the time you've done all that, then you focus onto the kidney, and you have two choices. Either you're going to explode the kidney or you're going to leave it alone. Because right now, the injury to the kidney is not making the patient life threatened. There is no life-threatening injury to the left kidney. Either the kidney is going to recover or it is going to become atrophic. and it can be dealt with at a later time. You have saved the patient's life from bleeding, from hemorrhage, by removing the spleen, packing the liver, and getting the patient to the ICU and get the patient warmed up. And if you have a luxury of time, you got it done very quickly, then you can ask the endovascular surgeon if you would like to have a look at that left kidney if time allows within the 4-hour, 5-hour period. If not, leave it alone.
Thank you, Dr. Kasim. Dr. Untract hasn't had an opportunity to comment in a long time. Sir, you have a comment?
Yeah, I would just say that honestly, this kind of a case, really, in the United States, I think all the people that practice, they know this, unless it turned out absolutely perfectly, in other words, not even long-term complications, back pain or that, whatever, it would be fairly indefensible. And if the patient happened to succumb to it, 27-year-old woman, maybe with young children, a family, that would be completely indefensible simply because this is not standard practice for a patient with a grade 5 avulsion of the spleen. And the kidney, you say she's stable from that. Well, that's only the case if the hematoma is not expanding. We have one CAT scan, haven't seen anything after that, and if the hematoma is expanding, then to not operate on that is another issue, and to not know whether it's expanding. These are all the things that we'd be taken to task for. People like surgeons like to badmouth lawyers, but in this case, they would simply say, Dr. Fraga, what would you do, God forbid, if it was your 27-year-old daughter? Would you say, okay, no, let's see what happens. Let's not operate. Let's watch her. I don't think you would. I wouldn't. No one here who's got, if you have children, you have children that age, no one would say that in this case. No surgeon would say that, simply because it's not standard, so a little risky. So now, having said that, if it turned out absolutely perfectly and no complication, no problems, okay, I salute you for doing it, but it's something that at the time it would make anyone practicing in the States extremely nervous, because you're choosing to put yourself on the high wire without a net and have to hope you're good enough to get across to the other side. And, and if you're doing it because you're really sincere, that's the best thing for the patient, that's fine. But I would not do it simply because I think I can pull it off. Not to be too forceful, but just the American perspective. And again, not seeing the patient, not being there, but, and I don't know what the other surgeons practicing in America, what they would say, what they would want, what they would do with their own family, God forbid, a young adult at that age, but I wouldn't. And I can't imagine anyone that would say, no, my daughter, I would do exactly the same thing.
All right, Dr. Fraga, I'm sorry. Dr. Fraga, I'm going to get a comment from Dr. Calais. He's been waiting patiently, and then we'll go back to you for a continuation, okay? Go ahead, Dr. Calais. Dr. Calais has no comment? Anything else before
no comments, no comments more.
Okay, very good. Thank you, sir. Anything else before we go back to Dr. Fraga for continuation? Okay, let's continue the case, please.
Well, after the discussion with the specialties, we defined, as we previously said, that for a non-operative treatment and transfer her to a trauma ICU. And there she was for 8 days, and the lab controls, just the special ones that we put here, and she was stabilized within like no hemoglobin dropping, and she had just WBC counting going up. And we, after 5 days, we did CT again, and there was like pretty similar to the first CT. At this time, she just presents a pleural effusion, and we did a thoracentesis. It was with no complications. So about the abdominal, specific in the abdomen, she was stabilized, so the hematoma didn't get worse, and she was still stabilized as we saw before. And next one.
So she received 2 units of red blood cells, 2 units.
That in the beginning of the attending, or what's the next? Oh, here.
She was Wonder Woman, Mr. Gustavo. She was a good campinera, Wonder Woman.
From Giovanetti, do you remember Giovanetti?
Yes.
And after 8 days of ICU internation, of ICU, she was transferred to nursing ward, and there she did vaccination, end of the resting, and she started to walk, and with no, I'm sorry, no questions of anything.
The
So
vaccination one because the spleen was embolized, or why was the vaccination, or was the virus?
no, she didn't do any procedure. So we did the vaccination because we discussed that she had a traumatic splenectomy. So she still had the spleen on her abs, but we could see in the second CT that there was no perfusion, so no functionality of her spleen. Okay. So we try to prevent any capillary infection.
And the patient was discharged after 10 days, and she came in the outpatient clinic 10 days ago. The patient was totally asymptomatic.
You say it has bleeding? No, no bleeding.
No. So it was a difficult decision, difficult case. I think most of the people would operate this patient, but sometimes it's dangerous to perform a non-operative treatment in case like this one. But when we asked for the patient if she was happy with the treatment, she told us, yes, very happy, because I am okay. I can do everything, but we are still following this patient. Probably we have another CAT scan with 2 months just to understand what happened with this spring, with the kidney, and with the liver. So final comments, it's a difficult case, but our team, we learned it with this patient. I don't know if in the next one, we will try a non-operative treatment again, because usually Dr. Carcin usually says it's good to sleep during the night. In this case, you cannot sleep during the night, because you never know if you need to operate during the night or no. Gary?
Yes, sir. Let's go to Dr. Alex. Final comment, sir?
Well, a great case, interesting combination of injury. You can argue with success. I'm going to say I don't have that much gray hair to basically have somebody like this admit to the ICU and do no intervention. And Dr. Untrak really outlined very well what's going on here in the States. Again, I don't represent the States. I work here. I'm in Philadelphia, Thomas Jefferson University. If this were a patient that would have come on my clock and have these CT scan findings, next thing would have been angiogram and take out the spleen. And then of course the kidney is it's a distractor there, and a question, you know, to other colleagues would be asked. You know, and then watch for the liver. Again, I'm not sure that she really needed vaccinations. I don't think there's any data to support that. My question for you is, how are you planning to follow up the kidney and the spleen, timing of repeat CT scan. As you know, we know grade 5 injuries have a high risk of developing, pseudoaneurysms, and then, maybe renal hypertension. Thank you.
Thank you, sir. That was a question for Dr. Fraga. Dr. Alex?
Yes, the idea is have a CT 2 months after the trauma. Maybe when she come back again, you order another CT. And maybe after 1 year.
Thank you, sir.
Can I say something?
Yes, sir. Dr. Rodriguez, your final comments, please.
I have to go. I think, for me, the conclusion, if I'm talking to residents and talking to people in Latin America, okay, definitely they don't have the facility to have these CTs in many hospitals, even in Latin America, unless you're working in Dr. Ordóñez. We had the Mayo Clinic, like a majestic private clinic. We talk about the real Latin America. Excluding Brazil, Sao Paulo, Campinas, you have a very high technology there. All this area. I think we have to emphasize that more likely with most people, we all saying the same thing. More likely most people will do is go to this patient hypotensive 8.2, go to the OR to do or explore the patient. But it is an option. It is an option, but in order to do this option, you have to have a place, you have an attending with experience, a real trauma surgeon there, which obviously we did. We have to have facilities to do an angiogram embolization. You have to ICU personnel. You see, we cannot generalize this is the way, because this is not the way. I have news for you. In the rest of the world, not everybody has this facility to do what we do. So more likely everybody will enter this patient, And for the residents who are listening, I have to emphasize to you that the guidelines, the East, West, all these are guidelines made for some doctors who collect data from 300 patients. They're very smart. They clean their hands like Poncio Pilatos. They tell you this is only guideline. It doesn't mean that is the way it has to be done. There is a role for thinking. Okay, that's all I want to say.
Thank you, Dr. Rodriguez. Dr. Rodriguez, Dr. Marcos would like to convey a message that appreciates you joining and that he really enjoyed your comments.
Oh, I thought he was going to send me a poem or something like that. Thank you. Thank you.
Let's go to Dr. Calais. Your comments, sir.
Yes, I have congratulations for the case. Very interesting case, very difficult decision. And I believe this case can represent one problem with all, as Dr. Rodriguez says, a problem if you have tools to try to make no operative management or operative management. And so you have only to see all the best things you can do with the results you have in your hospital. So if you don't have ICU, adequate ICU, don't have endovascular procedure, you can try to go to operation. If you have sometimes the patient is stable, you can go to ICU, can maybe angio, and then you can observe the patient. So it usually depends on what the results or the tools that you have in your hospital. It's very important to all people know all the procedures to treat these injuries, such endovascular treatment, no operative management or operative management. So it's very important to know this. Thank you. Congratulations for the presentation to Gustavo.
Thank you, Dr. Calais. And Dr. Untrack, your final comments, sir.
Yes, so a very nice result, and I don't want to be too critical, just to convey different contexts and balancing the risks, and but you were very brave and you got an excellent result, so I congratulate you for that. And certainly it's there are options, and maybe soon in the future that this will be also the standard of care for minimally invasive surgery.
Thank you, Dr. Untrack. And Dr. Kassim, you want to have the final comment?
Well, never argue with success of a surgeon when he's showing you his case. Surgery is knowledge and luck. Sometimes luck plays a big part. And in this case, I'm sure Dr. Fraga got very lucky. He had a bunch of people who all came to conclusion that this is the best way to manage this particular case and they applied it and saw success. But as far as I'm concerned, I would be scared to death to do something like this in United States, because there are people called lawyers, they are sharks, and they are watching for things going wrong somewhere here, and they will pounce on you. So it's an alternative that I will remember this for the rest of my days. But I don't know whether I would like to apply this on every case that I'm going to be seeing. Like I said, I like to sleep well at night, and surgery is my game, and I like it, and I like to stick with that. Thank you.
Thank you, sir.
Yeah, there is a lot of comments in the chat. If someone wants to talk by email, I put my email here, so you can ask by email. Sometimes there are students, residents, and they want to discuss because they are writing the chat. Thank you, everybody, for the comments. I think you learned a lot of this case. I think every day we learn with each case. It's difficult to take the decision, the correct decision, but we are surgeons, we are physicians, and keep safe, everybody, because we are in a difficult moment nowadays, and stay healthy, everybody. Thank you. And congratulations to Dr. Leticia for the first time she presented the case in this conference. She's resident in the 3rd year of general surgery. Thank you.
Thank you.
Congratulations.
Thank you. Nice to talk to you, Gustavo. Bye-bye.